Good morning, folks. I hope that everyone's had a nice, well, a day or so since the weekend now, but I hope that people have had a nice weekend, and I hope that you guys have been staying safe and healthy. I have an alarming number of students right now in my face-to-face classes who are out under quarantine with COVID. So I've also heard from a number of students though who have already had it, and I've heard a number of students say that it was basically like having a cold. Uh, but I've heard other people say that they were debilitated by it and they felt like it almost killed them. So I think it has a lot to do with genetics and various other individual risk factors and whatnot. Hopefully the vaccine will be distributed soon. Okay, so now that just about everybody's with us, just a few announcements that I want to reiterate here. Let me get the share screen going on the Canvas page here. All right, so you guys should see the Canvas page now. On last Thursday, I had an issue which caused me to have to post a recorded lecture for you guys last Thursday. And I must confess that it looks like a number of you guys never watched that recording. And I am able to look and see, who's gone to check it out and who hasn't. I can't, tell how long you stayed at the video once you clicked on it, but I can tell who clicked on the link and who didn't. And, I'm not calling anybody out personally. I do just want to say that, that is material that is going to be covered in your final and in your quizzes, and it's material that you're responsible for. So although we weren't able to have a live meeting, even though it was just a recorded lecture, you're still responsible for that content. So please do watch that. It's posted here. I added a new module on the Canvas page called Make Up Recorded Lectures. If you click on this, it should take you to a video from my YouTube station where I give the introductory lecture on psychopathology. And it's a version of the video that I recorded earlier this year. So you'll notice that my hair was a little bit shorter in the video and I was a little bit chunkier because I hadn't started getting back into running at that point yet. So, I look a little different in the videos, but it was only, say back in March when it was recorded, I think, but it's on my YouTube station. And if you click on the link itself here, I think it'll take you to my YouTube station. And you can see other videos that I have publicly posted there that you can check out. Once in a blue moon, I might even post, it's being slow, but go to my YouTube station, check it out. Sometimes I even post music that I record there once in a blue moon, but mostly it's just lectures. But in any case, there it is, Richard Carr, my YouTube station. So feel free to subscribe to my YouTube station. A little bit of shameless self-promotion here, but I'll be posting more videos to that station in the future. And I am trying to grow my audience on that station. So feel free to subscribe if you are so inclined, no pressure. Okay, so please do watch that recorded video is my point. My point is not to promote my YouTube station, but is to tell you guys where it is, how you can watch it. Please do watch that if you haven't. So today I'm going to be continuing where I left off in that recorded lecture that I posted for you guys from Thursday. Like I said, you guys are responsible for that material, even though it wasn't a live class meeting. I'm going to pick up there where I left off in chapter 14.
Professor Carr, I have a question.
Yes, ma'am.
Final. Can we look at old quizzes in order to study for the final? Or is there
Now,
not
I think you should be able to view your old quiz answers and the answers you got right and wrong. It's not going to allow you to retake the quizzes that you've already submitted, but you should be able to view your answers.
Yeah, that's what I was wondering.
Yeah, you should be able to do that, and I would encourage that. Yeah, that's a great idea. And yeah, so the final will not be cumulative. It's going to just be like the other two exams. And I also am going to have a designated day, and folks are going to have to, sign up for this in advance so I know what exams to open back up for who, but I will have a day also. It'll probably be the same day that the final is open, actually, which I will announce in the future. But I'm going to allow folks to retake their lowest exam if they want to. You don't have to, but you can retake your lowest exam. And what I'll need to do is I'll just need to know who is electing to do that and which exam you're going to elect to retake. So on that day, don't send me this information yet, by the way, until I ask for it, because I don't want my inbox to be flooded with these emails until I'm ready to receive them when that time comes. But when that time comes, you'll let me know which exam you want to retake, and I will open up another attempt for you on that exam and reopen those old exams. Now, keep in mind, because the exams are generated almost kind of half randomly out of a question bank, it's not going to be identical to your first attempt on that exam, right? It'll be a slightly different set of questions. Some of the questions will be the same. It just all depends on which questions are randomly drawn on that attempt out of the question banks. So we'll cross that bridge soon when we come to it, but the final will just contain the chapters that we've covered since the last exam. Okay.
Like the midterm where it's 100 minutes. Wait, was it 100 minutes? Okay.
Yeah, so it'll be open book and timed. Yeah.
But we don't have to download any Proctor.
No, and starting next semester, I think I am going to start having to use a webcam proctoring service because the college is really strongly encouraging instructors to use it almost. We haven't yet been required to use it yet, but I have the feeling that that's coming down the pike, and I might as well start using it. So when that time comes, I'm already doing it. So I think the college is going to start requiring the use of these webcam proctoring services because it's just an issue of academic rigor, and I get that. I think I do try to offset this by making my exams pretty moderately difficult. I don't know, but I don't know. We'll see what happens next semester on web proctoring. Any other questions, house cleaning related, before we continue where I left off in chapter 14 in the recorded lecture? Okay, so in the recorded lecture, I talked a little bit about how we define mental illness, or psychopathology is the term that we use. And I spent a little bit of time exploring the history of the DSM and some of the questions that we have to ask ourselves when trying to determine whether a behavior pattern is in fact an example of mental illness, or is it actually just an example of eccentricity, right? So just to kind of recap that a little bit for those of you who didn't watch the recorded lecture, and I know there are probably about half of you who didn't. again, when we define something as psychopathology, the more we can answer yes to these questions, the higher the likelihood we're talking about disordered behavior or disordered thinking or something that qualifies for a diagnosis. But we have to be careful about not being too quick to label unusualness as mental illness, right? And we've been guilty of this in the past as a profession. For example, when the first DSM came out in 1952, and I don't want to rehash my entire recorded lecture, but when the first DSM came out in 1952, homosexuality was categorized as a mental illness. And back in the 1950s, many people who we would now just call gay were diagnosed as being mentally ill because they were sexually attracted and romantically attracted to individuals of the same sex, which now is, there's nothing remarkable about that. You know, it's like it's just, we've become much more tolerant and open and accepting of LGBT folks in our culture. And as far as I'm concerned, that's a good thing. You may not agree with me on that, but I tend to think that it's a good thing. I hope that you agree with me on that. But in any case, that was an example of a behavior that, you know, that we pathologized because we had moral misgivings about it, right? Many folks have religious or moral scruples concerning sexual orientation. So we confused a religious moral scruple with a mental illness, right? When in reality, you know, an incredible number of people actually are, you know, either somewhat bisexual or lean towards being gay, right? It's on, I'd say it's probably on a spectrum. You know, most people are, you know, somewhere between completely straight or totally gay, right? According to the human sexuality research, at least. But now this is just seen as a normal variation in human behavior, right? And most of us these days don't really consider it unusual at all to meet someone who is gay, right? And in fact, I bet there's at least one or two folks in this class who would identify as gay or bisexual. And more power to you, right? So even though we strive to be scientific about defining mental illness as a science, we haven't always been perfect at this, right? And that's why the DSM is always going through revisions. We're now on the 5th edition of the DSM. The 5th edition came out in 2012. They're always editing it. And sometimes disorders get added, sometimes disorders get deleted. Is anybody familiar with any disorders that used to exist in the DSM-4 and then when the DSM-5 came out, didn't exist anymore? I know of at least one. Asperger's syndrome. Has anybody ever heard of Asperger's syndrome? So in the DSM-4, there was this condition called Asperger's syndrome. It wasn't, they deleted it from the 5. And now if you were diagnosed with Asperger's syndrome, the diagnosis that you get these days would be high functioning autism, right? So sometimes they just change the names of disorders. Sometimes they delete disorders entirely. Sometimes they add disorders. And sometimes there's controversies around whether or not something should be considered a disorder. In fact, a lot of professional psychologists are divided professionally on whether or not sexual addiction should be considered a mental illness. And they decided not to include it in the DSM-5 as a disorder. Whereas there are a lot of professional psychologists who've been making a strong argument that actually sexual addiction is a real thing and it should be in the DSM as something you could get diagnosed with, like any other addiction. So again, there's still argument about whether or not we should consider that disordered or not, right? So these are general questions that you see listed here in this slide, are the sorts of questions that we want to ask when we are considering the question of whether or not a behavior is disordered. Also, in the recorded lecture, I talked a little bit about etiology, review what I said about that. I don't want to go over that again. Be familiar with those models of etiology. I spent some time talking about various types of anxiety disorders, up through phobias and generalized anxiety disorder and OCD. I talked a little bit about, which brings us to the point where I'm picking up today. So the next anxiety disorder that I didn't make it to in the recorded lecture is post-traumatic stress disorder. Post-traumatic stress disorder, correct me if I'm wrong. I don't think I made it to this. Someone please correct me if I did talk about this. I think I stopped after OCD. Is that correct? Okay. So post-traumatic stress disorder is an anxiety disorder which is such a big syndrome of symptoms that really it's much more than an anxiety disorder. It's debilitating for those who suffer from it because it involves the reliving of extremely traumatic events caused by triggers that cause the person to relive some sort of extreme trauma that they just can't shake. And the trauma causes nightmares where they relive the traumatic event. Often there's a certain degree of survival guilt going along with this experience. So for example, I had a student a couple of years ago who was responsible for the death of his wife. It was an accident, but he was driving. His wife was the passenger. And he was distracted while driving. I don't know if it was his phone or something, but he got distracted, and I don't know the whole story, but he caused a serious car accident, which he survived, but it killed his wife. His wife died in the car accident. And he was having some serious psychological trauma over this, the guilt of having caused his wife's death and having survived it. You know, the sadness and depression, the nightmares. He couldn't get behind the wheel of a car without debilitating panic attacks and going into tears. Classic PTSD. For a lot of other folks, it might be associated with some sort of sexual assault trauma. And in fact, most of the good therapies that exist for treating PTSD, as we'll see in the video I'm about to play, were originally developed for treating individuals who are rape survivors and had PTSD from that. So there's this reliving of the trauma, this instability in mood that goes along with it, this difficulty sleeping, this erraticness, and constant vigilance about triggers causing an episode. We also hear a lot about PTSD associated with war veterans. And, love him or hate him, I know he's a controversial president, but Trump has been talking about ending the war in Afghanistan, bringing our troops home from Afghanistan. And, we've been there, 19 years, right? We've been now in Afghanistan. I think it's the longest American war. Correct me if I'm wrong. And I think now we're in a situation where we've had, two generations, father and son both fight in Afghanistan, right? Which is kind of crazy when you think about it. And we've also had the war in Iraq that went on for many years. And because Pensacola State College is a very military-friendly school, I've personally had the honor of serving a number of veterans over the years. And unfortunately, I hate to say it, many of them suffered from PTSD and still do because of the sorts of traumatic experiences that you experience in a combat zone. If you survive that, often you come out of that with some memories you'd rather not have. So a lot of the conversation these days around PTSD centers around military service members. So I do have a video I want to play at this point that focuses on PTSD, particularly with regards to military veterans. And like I said, I am aware of the fact that we often do get a lot of veterans at Pensacola State. So I'm keenly aware of the fact that we may have people in this very class who can relate to some of the experiences described in this video. And it's an emotionally heavy video. It's about 13 minutes long, and it gets emotionally heavy at a couple of points. There's nothing violent that's shown in the video, but these are grown men who are getting kind of weepy and emotional, discussing their experiences with PTSD and their experience of losing people they loved and cared about in combat, and the effects of this experience on their families. And it also follows them as they go through psychotherapy through the VA hospital. And so just a heads up that there's it's emotionally heavy. And if there are folks in the class who, if this hits too close to home, then I get it. If you need to, excuse yourself and go walk your dog for the next 10 minutes or something, that's going to be about a 13-minute long video. So I'm going to go ahead and play it. Hopefully you don't need to do that, but I do understand that some folks may have some significant experiences that might make this particular video difficult to watch for some folks. Please let me know if the video does not work. I'm going to assume that it is.
We've seen a lot of stories about veterans and post-traumatic stress disorder, but tonight, for the first time, we're able to show you new therapies that are changing the lives of vets and their families. 2 million Americans have served in Afghanistan and Iraq. The Veterans Administration tells us that 1 out of 5 suffers from PTSD. One reason we're seeing so much of it is because many of our troops have been ordered on combat tours 3, 4, or even 5 times. The VA, overwhelmed by the need, decided to try new treatments that were originally designed for rape victims. Over 2 months, we were allowed to sit in and listen as our troubled veterans fought the war within.
How can you live the life where everyone's afraid of you? You go to town and people says, that's the crazy vet, don't mess with him.
My wife told me, something's got to change or we got to leave.
When you try to talk to somebody that hasn't been there, hasn't experienced it, they don't understand. And so you just kind of get laughed at.
Yeah.
The 16 men around this table arrived via Afghanistan, Iraq, or both. Some are here from Vietnam.
I see that I do have, that opportunity to pick myself up at 63 years old and start all over again.
They've started over again many times, but their path has led back to isolation, drugs, booze, and suicide attempts. Now, they're in the VA hospital in Little Rock, Arkansas, where they will live for 8 weeks to break through the emotions that have derailed their lives.
Depression, anxiety, anger, worthlessness, guilt.
Guilt?
Survivors, guilt. Why me? Why am I alive? Why are they not? That's one of the hardest thoughts to deal with,
Eric Collins was wounded in a rocket attack in Afghanistan. Over a year, 17 of his buddies died. How did you cope with these feelings of anger and depression and guilt when you first got out?
Alcohol, and lots of it. That's where it started off. And alcohol led to my depression worsening, which led to more substance abuse. Crack, cocaine is my drug of choice. So my whole life spiraled downward out of control.
To take control, Collins volunteered for one of the new therapies called prolonged exposure. It forces him to work at remembering every detail of what he's tried to forget.
Next thing I hear a loud boom. My ears start ringing. And I wake up, open my eyes, and I'm on the ground.
Dr. Kevin Reeder runs the program.
How are you feeling at this point? What were you feeling at that time?
Anger, I'm scared. Feeling pain. My leg, my back, my arm, my whole body.
Okay, let's go from the beginning. Gotta keep doing this.
Next thing I know, I hear a loud boom.
They call it prolonged exposure because Collins will relive the story of the attack 5 times a session. There's a tape running, and he'll listen to his memory throughout the day to break its power. Tell me about prolonged exposure therapy.
Sure. They've done everything they can to push these memories away. In the process, they haven't gained a full realization of the impact and the meaning that these stories have on their lives. I like to use the term, we're staring the dragon in the eye.
Where did these therapies come from?
A lot of these therapies came about with survivors of physical or sexual abuse, those types of traumas.
What are the similarities?
The symptoms. The symptoms. The avoidance, the isolation, the hypervigilance, the extreme anxiety, irritability, inability to sleep, nightmares. Same thing. Different sources, but same thing.
Can't move my legs, can't move my arms.
What does that do for you?
It helps me to get past the guilt, survivor's guilt. And that's a building block. Every time I get through it, I get stronger. And it helps every time.
It's okay to be alive.
Yeah.
And you weren't sure that was true before.
No, I didn't want to be alive. I wanted to be right there with them. You know, the whole purpose of life was gone.
To lose one of your buddies in a firefight, you don't want to see that. You don't want to feel that again. And so, yeah, when you get back to the rear, you're pissed off because you don't want to get close to anybody anymore.
Anthony Appolito experienced those multiple tours we talked about. He fought for a year in Afghanistan, spent 1 month at home, then went to Iraq, and later Afghanistan again.
The more deployments you get, the more time you spend out there, it just keeps on stacking. I mean, the first one, it hurts, but you don't get really time to heal. And then another one happens, and then another one.
On his first tour, Appolito's patrol was ambushed. 2 buddies died, and 20 were wounded.
I had no weapon, no one had my back.
They write about days like that in the other key therapy here called cognitive processing.
After a trauma or multiple traumas, often a person can believe the world just is a dangerous place. And so what we do with CPT, cognitive processing therapy, is they write an impact statement at the beginning of therapy to show them the impact of the trauma on their lives and on their beliefs.
Yes, I have worked on it.
They read that statement about the trauma to the group, and then they discuss how their lives are still held in the grip of
I
war.
probably still need some work.
I never had a fear of life. I never had a fear of living. I never had a fear of going to the gas station and getting shot while I'm pumping gas because I needed gas in my car.
They plow through a workbook that challenges their guilt with statements like, "I shot a woman in combat, therefore I'm worthless," or "My friend was killed by the enemy, I'm responsible." Cognitive processing tries to put the war in the past and help them re-examine who they are today. It's tough. We noticed this on Apolito's workbook.
How many of you would go back to a deployed environment with your branch of service right now if that opportunity was available to you? A lot of hands up. Real quick, why are your hands going up so much?
You miss everything about how hard it was, how bitter you got, how angry and emotional, the things you saw. And you missed that camaraderie, that brotherhood, your buddy. Yes, that downtime, the struggling with things, man, it's everything, but you miss it, you mourn that. It's weird. It's that intimacy. I will never get that back. None of us will ever get that back. And that's
Gable Darbone never planned to be part of that brotherhood he mentioned. In 2001, he was out of high school, headed to college. But then 9/11 pushed him to an Army recruiter instead.
My mom, I remember she was crying in the kitchen. She goes, Gable, you don't know what it's like for those boys coming back from Vietnam, how hard they had it, and what they came back with. I said, Mom, it's different, though. We got attacked. I said, I'm volunteering. I said, I'll take anything. I'm willing to give my life. That's how strongly I felt.
I joined to serve my country. I joined to protect my freedoms, my future kids' freedoms.
Darbone was one of the most thoughtful people we met. He served in Afghanistan and Iraq. One day, his unit was clearing a house. It exploded, and 2 buddies were burned.
You can get angry, get mad. We get very angry. And we took it out on certain people, and you enjoyed it at the time. You did.
You did things to Iraqis that you're not proud of.
Of course. But that was surviving emotionally, mentally. I was never a violent man. I became different, slowly. We all have that instinct, that survival instinct. And that survival instinct is very real.
At home, the survival instinct didn't let go. Darbone was like most other vets here. Certain triggers brought the instinct back. The smell of diesel returned him to his combat outpost. Crowds made him fearful.
I started isolating. I couldn't do anything. My dad had to come over and mow my lawn. Mom had to come over and pay my bills. I wouldn't leave my house for a day or two. I didn't want to make small talk. I didn't want somebody to ask me, hey, how you doing? I didn't like those words. I got very secluded, like a recluse.
For 9 years, Darbone told himself he was okay or would be okay. And then the folks at work urged him to get help. This was Darbone after 7 weeks of self-examination as they all prepared to go home.
And when I went in, I had a heart. And I volunteered. I don't blame nothing on anybody. I don't blame nothing on myself. I don't blame nothing on my leaders. In fact, I had good leaders. I blame nothing on the Army. I think it's just the way it is. And it sucks. I hate it. I hate it. I don't want to go home. People would always ask me when I came back, so what did I tell my boyfriend when he comes back, or how do I approach this to my son? I said, when he starts talking, just listen. Yeah, don't judge it. Just listen.
There is probably a soldier or a Marine sitting alone watching this on television right now.
Thousands of them, I'd imagine.
And to them, you would say what?
I hope you can find the courage to get help, because all you're doing is killing yourself. And you don't have to live like that. There's good people in this world that are willing to help you, and it's been the hardest thing for me to do, but I wouldn't have changed coming here for the world.
In our 2 months here, 28 men sat around the table. 3 couldn't endure it and dropped out. The VA finds that nationwide, about 77% graduate from this with a drop in their PTSD symptoms. It's progress, but they also have a saying around here: there is no cure.
I don't think there is a cure for what we're talking about. We're talking about living. and putting people more in touch with their lives and emotions and good days and bad days. This isn't cancer. We can't go get it. We have to teach people that they can live with this and live a valued life, a life they want.
After 8 weeks here, how you doing?
How am I doing? I don't know yet. That's an honest answer. But I know deep down inside, things will work themselves out.
Minutes rewind.
All right. The other diagnosis that I want to briefly discuss for a second, listed on this slide, the adjustment disorder. This is a diagnosis for folks who have gone through some significant stressful events in life and are having trouble bouncing back from those stressful events. However, we're not talking about the sort of stressful event that would rise to the level of trauma that you would see with PTSD, right? We're talking about more of the major life stressors that everybody experiences eventually, like losing a job or experiencing the death of a family member or going through a divorce or something like that. These are really stressful events that most people will go through, at least some of them at some point in their life. And most people are able to bounce back from them relatively quickly. However, some folks have trouble bouncing back from these sorts of life stressors. And that's what we're talking about when we talk about an adjustment disorder. We're not talking about, you just saw someone you really care about die in front of you in a violent way and you're having nightmares about it. That's PTSD, right? But nonetheless, you've experienced usually some major loss or some major life change that you're really having trouble finding your way around in life. You see a lot of adjustment disorders in the counseling arena. There's a difference between counseling psychology and clinical psychology, which basically entails the severity of the symptoms, right? So when we talk about clinical psychology, which I'm getting ahead of myself a little bit into the next chapter, but when we talk about clinical psychology, we're talking about psychologists who specialize in treating serious, relatively debilitating mental illnesses like serious depression, bipolar disorder, schizophrenia, heavy diagnoses. Your counseling psychologists are going to be your sort of folks who do psychotherapy more geared towards folks who are experiencing adjustment disorder related issues. Like folks who are going through a divorce or experiencing a personal loss, or, maybe, their career has taken a nosedive and they're trying to, put their life back together, that sort of stuff, right? Those are the sorts of adjustment disorders that you see routinely in a counseling psychologist's office. However, when it comes to the more serious mood disorders, which we come to now, you're more likely to need the help of a clinical psychologist or someone with a significant degree of training, the more significant you get. And depression is, I'm not saying that a master's level therapist or a counseling psychologist can't help treat depression, because there are some competent counseling psychologists out there who do good work in this area. But major depressive disorder is a debilitating condition. And this is a personal topic for me, because I have struggled with major depressive disorder in my adult life. I've had a handful of episodes, I'd say maybe 2 big episodes in my adult life that really looking back on it, were really serious depression episodes, like debilitating. And so this is something that I can personally relate to experientially, although it's something that I've had under control for a number of years. And, I'm pretty much an open book. Anybody who wants to talk to me one-on-one about, what I do personally to fight depression and stay in a good place, I'd be more than happy to talk to anybody about it. Although I'm not a psychotherapist, so just keep that in mind. But this is a struggle that I can personally relate to. And I'm not alone. In fact, major depression is often referred to as the common cold of mental illness, because so many people will experience it in their lives. Up to 16% of Americans will experience at least one major depressive episode in their lifetime. All right, so we're talking almost a fifth of everybody will experience at least one episode at some point in their life. So, this is something that's a personal topic for a lot of folks, and I bet for some of you guys as well. But when we talk about depression, we're talking about major depressive disorder here, we're talking about something that's beyond just the blues. We're talking about a set of symptoms in which the person loses interest in things they would normally be interested in. Their energy levels are beneath the floor, right? People can't get out of bed. Oftentimes, they completely lose their appetites, or maybe the opposite. They're not sleeping at all, and all they want to do is eat. One of the telltale signs that someone is experiencing a major mood disruption is it disrupts sleep cycles and eating. So for a lot of folks with depression, this will manifest as not eating at all and just never getting out of bed. For other folks with depression, it's less common, but for some folks, it will manifest more as nonstop eating and, maybe a lack of sleep for some folks. But there's almost always a disruption of sleep and a disruption of appetite, and there's a loss of interest in activities that you would normally get really excited about. Also, often feelings of guilt that come along with this, feelings of hopelessness, and often crying spells. I know for me, when I was experiencing my most severe depressed episode years ago, I would cry on a dime for no reason. I remember one time when I was watching, I was experiencing the last major depressive episode that I had years ago, and a commercial for SeaWorld came on TV. And there was a brief video clip of a dolphin playing with some kid, and it just made me just start weeping, like something out of a comedy movie, ridiculous. It was, it wasn't funny then, but it's kind of funny now when I think back on it. But just uncontrollable weeping for no reason, right? Just because I saw a video clip of a dolphin, right? And, unbelievable feelings of guilt for no reason, feelings of just feeling like, the world would be better off if I didn't exist, or some such nonsense like that, right? Anybody have, I know this is an incredibly personal topic, but if anyone cares to share, does anyone else have any personal experiences with depression? Any of this sound familiar? I understand folks may not want to share on this topic, and I am unusually open about this stuff, probably. Maybe even more than I should be, but I don't really think so, though, because I feel like it's important to humanize this topic and dispel some of the stigma associated with seeking help for mental illness. So thankfully, it's something that I seem to have conquered and have under control. And, I do a lot of things to keep it that way. Like I have a meditation practice. The first thing I do every morning when I wake up after I fed my animals is, I sit down and I meditate, and I have a quiet time, where I pray and meditate, and, I run 4 or 5 days a week. So physical activity is a big part of me staying healthy. I try to keep my diet in pretty good shape. I try to avoid, excessive alcohol consumption. I don't really drink much at all, actually. And for many years I had to take an antidepressant, and these days I don't need to anymore, but I needed to for a number of years, and I had, no problem taking it when I needed it. So some of you guys are sending me some private testimonials regarding your experiences with depression, and I appreciate you opening up. I understand it's something that folks may not want to publicly share. I get that. I respect that. So, yeah, that's major depressive disorder, and it's a beast. But the good news is there are a lot of effective treatments out there, which we'll talk more about in the next chapter on psychological treatments. Anxiety and mood disorders in particular. The good news is that, yes, they can be debilitating. And when you're going through an episode, it really, the world can feel like an incredibly dark place, and it really doesn't feel like you're going to come out of it. Trust me, I know. But the good news is that there are effective treatments out there, and you just have to stick with it until you find an effective treatment that works for you. But eventually you will find an effective treatment, and you will get your life together. You just have to stick with your future. Yeah, it's something that can be managed effectively and treated. That's the good news. Now, there's a more mild form of depression that you can be diagnosed with called persistent depressive disorder. And this is sort of a mild depression that lasts for years. So instead of the person, being suicidally depressed where they can't get out of bed and, they're losing weight and not eating, that's, a level of depression where that's major depression. You can be hospitalized for that, right? But with persistent depressive disorder, you have a more mild, low-grade depression that lasts and lasts and lasts, and that just doesn't seem to go away. This is much less common than major depression. So major depression affects 16% of the population. Only 2 to 3% of the population is affected by persistent depressive disorder. This used to be referred to as melancholia, by the way. It was an old school term for this. I still kind of like that word, actually. I like the word melancholy. It's also a great Smashing Pumpkins album, Melancholy and the Infinite Sadness. Check it out for you alternative rock music nerds. I'm sure you're familiar with it already. Okay, so the interesting thing about depression statistically is that cross-culturally, everywhere it's been studied, women get diagnosed with depression at about twice the rate as men. Now, obviously, there are men who experience it. I'm one of them, as I've mentioned. But statistically speaking, men experience it at a much, or at least get diagnosed with it at a much lower rate than women do. So there are different theories on why women get diagnosed with depression more often than men. One theory is that it's just because men, this is a more sociological theory, that men tend to be socialized to, keep things to themselves more and, be more masculine, so to speak, and suffer in silence and not seek help, right? That it's basically an effect of toxic masculinity that we basically teach little boys growing up, to suck it up and don't cry. And this results in men as adults not seeking help for their mental health issues when they need to. That's one theory. Another possible theory is that, is my video not sharing? I didn't realize that. You guys have been hearing me, right? For some reason, my camera had cut out. Okay, I think my camera is back on at this point. But anyway, that's one theory. Maybe it's just the way that we socialize men, and, because of that, men just aren't speaking up and not seeking help, and therefore not getting diagnosed. So men do experience depression, according to this theory. They're just not getting diagnosed because they're not seeking help. Another theory that's mentioned in the slide here out of the textbook is that the internalization theory and externalization theory, which is that basically women tend to internalize stress and men tend to externalize stress, right? So internalizing would be, turning your negativity towards yourself, through like depression or anxiety. Whereas men would turn their negativity outwards towards, external outlets, right? Like alcohol or drugs or getting into fights, that sort of thing. I don't know. What do you guys think? Do you think there's that this theory holds any water? Do you think that that women internalize their feelings more than men? I don't know. I don't know what to make of it. I don't really have an opinion on it. Okay. The other major mood disorder that I want to discuss today is bipolar disorder. And bipolar disorder is characterized by a cycling either between mania and normal mood, or mania, normal mood, and depression, right? So if primarily your cycling is characterized between manic episodes and a normal mood state, then that's what we would characterize as bipolar 1. On the other hand, if your cycling includes depressed episodes as well, then that's bipolar 2. So bipolar 1 does not contain the depressed episodes. Bipolar 2 does. What they both have in common, though, is the presence of manic episodes. So when a person has a manic episode, they have an episode in which they experience heightened euphoria of mood. Often there's an increased degree of irritability that goes along with this. But there's this increased irritability and euphoria. And often individuals who are manic will get flights of fancy. In other words, they will get these big ideas, these big grand ideas that seem like a really good idea to them at the time. And other people seem to be unable to convince them that, hey, this is a bad idea. So for example, a buddy of mine who is a local artist got this harebrained idea a couple of years ago during a manic episode because he was off of his medication. And I'll talk more about the medication in a second and why he was off it. He was off his medication and he got this harebrained idea to take out this massive loan and try to start a local art gallery studio, right? He didn't do any research to see if there was going to be a market for this place or if there was any way this place was going to try to make any money whatsoever. He just went out, somehow found someone that would give him this huge loan, right? And he went and spent thousands of dollars renting this studio space and went at least $20,000 into debt before, and about a month and a half having to close the doors to the place, right? Because it didn't make a penny. He didn't do his research at all. It was a total harebrained, unresearched, unplanned execution, right? And now he's in debt. For years, he'll be spending the next several years paying off the debt accrued from that loan, right? That's the sort of thing that people do when they're manic. Also, people often tend to get hypersexual when they're having a manic episode. One common feature of mania is acting out with multiple sexual partners in a way that the person later comes to regret. Seeking out lots and lots of sexual stimulation. Not all people experiencing mania have the hypersexuality component, but many people do. For other people, it's spending lots of money in a short period of time. But what they all have in common during mania is there's this impulsivity and this feeling of, I've got some really good ideas here and you can't be talked out of it, right? And oftentimes you will later come to regret the decisions that you made while manic. Does anybody know anybody with bipolar disorder who, did my camera go out again? My camera keeps going out, apparently. Does anybody know anybody with bipolar disorder who, oh well, I'm not going to keep fighting with my camera. Does anybody know anybody with bipolar disorder who's done some things while manic that they've later come to regret? Any personal stories? Any stories of anybody you know? I've seen people do some real, I've seen people do some things to wreck their lives while manic, honestly. So that's the hallmark of bipolar disorder, is the presence of mania. Bipolar 1 is the mania without the depression. Bipolar 2 is the mania cycling between depression and mania.
Could bipolar also be like a fluctuation in like moods, like severe mood swings, or is that something else?
So if you're having severe mood swings that are cycling extremely rapidly, like say, you have depression and mania within one day, there is a form of bipolar disorder that I didn't mention that's a lot more rare, but rapid cycling bipolar disorder. It could possibly be that, or it could also be a symptom of borderline personality disorder. Borderline personality disorder often includes extremely rapid mood swings, often within hours of each other, right? So we could look at rapid cycling bipolar. We could look at borderline personality disorder, but we would also have to look at substance use too, right? There are certain substances that, when used, can cause mood to fluctuate. So you got to look at substance use too. There are a number of things that you would need to rule out. But yeah, it could be a possibility: rapid cycling, or borderline personality disorder, or substance abuse disorder. An interesting thing about bipolar disorder is that a lot of artists and writers over the years, a lot of famous artists and writers have been diagnosed with it. Like Michelangelo and Vincent van Gogh, who, anybody know what Vincent van Gogh famously did during one of his manic episodes?
Didn't he cut off his ear?
He did. He cut off his own ear and presented it to, I believe, a cousin as a gift, right? If I'm not mistaken.
Yes.
Yeah. And I'm unclear on the, my camera keeps cutting out in and out. I'm unclear if the ear was intended to be a platonic gift to this cousin, or if it was like a romantic gift, like he was in love with her. I don't know. I've heard different versions of the story. So some folks believe that he had bipolar disorder. I've heard other people say that he might have had schizophrenia. Georgia O'Keeffe, Ernest Hemingway definitely had bipolar disorder. There's almost no question about it. He died by suicide, which unfortunately is a common way to go. Also, so did Van Gogh. Van Gogh died of suicide as well. I forgot to mention that.
Ate his oil paints.
What was that?
He would eat the yellow oil paint.
It'll make him hallucinate. Yeah, he ate
oil paint.
So he poisoned himself to death slowly, right?
Because he thought the yellow paint would make him happy.
Yeah, that's really fascinating. See, I didn't know this stuff. I'm always learning more about Van Gogh from students. He's a fascinating figure. We have one of his paintings on the side of Building 14, where my office is on campus, The Starry Night. And he had this really surrealist sort of, what was his style called? Impressionism, I think? Or was it surrealism? I think it was Impressionism. But Hemingway, the writer, he also had bipolar disorder, and unfortunately, he took his own life largely as a result of his alcoholism combined with his bipolar disorder. And a lot of times, folks with mood disorders will often have substance abuse issues that will go along with it, right? And that's what we call comorbidity when you have two diagnoses at once. But a lot of times folks with substance abuse issues, people with mood issues will have substance abuse issues too, because they're basically trying to self-medicate, right? And if you look at a lot of the emerging research on addiction, actually you find that a lot of addicts are actually just self-medicating, trying to, treat their own trauma unsuccessfully, but nonetheless, they're trying to self-medicate in some fundamental way. So bipolar disorder is a lot less common than depression. 3 to 4% of the population experiences it. Interestingly enough, there is also no difference between men and women in the rates of bipolar disorder. So although there's a big difference between men and women in the rates of depression diagnosis, we do not see this difference. Men and women are equally diagnosed. And there's a lot of overlap between bipolar disorder and the next mental illness that I'm going to talk about momentarily, schizophrenia. Like schizophrenia, bipolar disorder is equally common among men and women. And like schizophrenia, bipolar disorder tends to emerge when you're young. So during late adolescence or early adulthood. So somewhere between the age of 18 and 30, typically, statistically speaking, is when the diagnosis, when the symptoms, when the emergence of the disorder is going to happen during young adulthood, typically, or late adolescence, you see a bipolar diagnosis typically happen. You also see that with schizophrenia. Interestingly enough, also with schizophrenia and bipolar disorder, both disorders are heavily heritable. So when we say that a disorder is heritable, that means that it's affected heavily by genetics. So if you have a sibling or a parent or close family member who has bipolar disorder or schizophrenia, you have a much greater statistical likelihood of you developing that disorder yourself. Of course, it's not a guarantee, but it's an increased likelihood. So that brings us to schizophrenia. Schizophrenia, although there's a lot of overlap between schizophrenia and bipolar disorder, ultimately, schizophrenia is categorized as a psychotic disorder, whereas bipolar disorder is categorized as a mood disorder. Now, bipolar disorder can become so severe that the person starts to become psychotic. And in that case, we would say that it was bipolar disorder with psychotic features. But in most cases, bipolar disorder is purely a mood disorder. And only in the severest cases does the person actually become psychotic. So when we say that a person is psychotic, that means that they have lost touch with reality, essentially, in some way. So to be psychotic means that fundamentally your perceptions of the world are not in line with how the world actually is. And the symptoms of schizophrenia have to be present for at least 6 months before a diagnosis can be made. The symptoms of schizophrenia are typically divided into two broad categories: positive symptoms and negative symptoms. So all the positive symptoms are listed as 1 through 4, and the negative symptoms I'll talk about momentarily. But when we talk about positive symptoms, we're not talking about symptoms that are good. We're talking about symptoms that are there that shouldn't be. So when you see positive, think added. So positive symptoms are symptoms that have been added. Negative symptoms are things that are missing, right? Like sleep or hygiene or just taking care of oneself, right? Not doing the things that one is supposed to be doing. Those are negative symptoms. Positive symptoms are things that you're doing that you shouldn't be. Does that make sense? So the 4 types of positive symptoms are delusions, hallucinations, disorganized speech, and disorganized behavior. So delusions are beliefs about the world that aren't true, basically. So if I believe, for example, that all of you in this class are out to get me. That everybody in this class, all my students, are conspiring to get me fired from my job, which I don't believe, by the way. Why would you guys do that? I don't think I've done anything to deserve that, right? I hope not, at least. But if I were to really believe that, that would be a delusion of persecution, right? Or maybe I believe that that the newspaper contains secret coded messages from the CIA. Has anybody ever seen the movie A Beautiful Mind, right? Based on that, it's based on a true story. But maybe I believe that the newspaper contains secret coded messages from the CIA, right? A referential delusion to the newspaper. Or maybe I believe that, you know, I'm the president of the United States. That would be a delusion of grandeur. Or maybe I believe that I'm Jesus Christ or Muhammad or something, right? That would be a delusion of identity. Or maybe I have a delusion that I've murdered a bunch of people that I've never met in my life, right? A delusion of guilt. Believe it or not, that one's actually common. Or maybe there's a delusion that someone else is controlling my thoughts, delusions of control, right? But what all of these beliefs have in common is that they don't match up with reality. People with schizophrenia almost always suffer from delusions. And they often suffer from hallucinations as well, which are sensory experiences of things that don't actually exist. So a delusion is a false belief, but a hallucination is a false sensory experience. Does that make sense? Does that difference, you know, does that capiche? Okay. So hallucinations are false sensory experiences, and people with schizophrenia often experience them in addition to their delusional beliefs. So negative symptoms, like I said, are things that you want to see that are lacking, right? There's a lack of emotional response. We call that flat affect, slowed speech, monotonous tone of voice, taking long pauses before answering, not being able to complete a sentence, right? And for whatever reason, these symptoms seem to be more common in male patients. So what I want to go ahead and do at this point, and we have a few minutes left. Let me see, I had a video on schizophrenia here that I was going to play. I don't know if I have time at this point. I have just enough time to play a couple. I might not be able to play all 4 patients that you see in this video. The video is 9 minutes long, but this will be the last thing that we'll look at today on schizophrenia. And then we will finish chapter 14 next Monday and probably start chapter 15 as well. I may decide to post a supplemental video lecture over Thanksgiving break so that we can just start fresh on chapter 15 next week. If I do that, I'll let you guys know. Let's go ahead and take a look at this video on schizophrenia. Don't be confused by the terminology flashing across the bottom of the screen in the video. Just pay more attention to the symptoms of the individuals being shown in the film and how they line up with the positive and negative symptoms that I've just been describing. Okay, the video should be playing now.
I got TV tooth, they call it. TV tooth is when they surprise you and they put little needles in your scalp. And they listen to you for years if you know it or not.
Really?
I didn't know it. And they have this really fantastic, expensive equipment they touched me with. It's, they said to me, hey, we can check your head, you know, for if your bump shows up bruised and the electricity's a little different across the scalp of your scalp, we'll guarantee you Social Security from that injury on its own. It's considered like cerebral palsy, but it would be muscular dystrophy kind of thing. And so I said, no, I don't think about it. And the next day he comes back and says, did you think about it? get me right, and all that. I said, well, okay, I'll look at it. Okay, let's go. And when they put the needle in, the last one they put in, they went like this. So when they did it, I had a thought when they pulled them out permanent, but they left a little teeny little barb in every one of the places they put me. And they recorded it. And one person who wanted it didn't. Someone else sold it to someone else. I don't know who, but they're able to give a response back because of how thick the dental is in my teeth. How thick the dental is. And with the needles, they're easy to focus a heavier field of pickup reception because of all the fillings I got. And so
Who's listening?
I think it's people like at Stanford and technicians, wealthy technicians and people that do stuff like NASA or any of that.
Okay, so that seems like my camera's working for the moment. Oh, now it's out again. That is a pretty good classic video illustration of symptoms of schizophrenia. So we have a little bit more material to finish up in chapter 14. Like I said, I may decide to just go ahead and post a recorded video over Thanksgiving break to just finish up chapter 14 so we can go ahead and get started on 15 on Monday. If I do that, I will let you guys know, and I'll ask that you guys watch it before Monday, but of course I can't enforce that. But I hope that everybody has a nice Thanksgiving if you're celebrating it. I know that it's sort of a different kind of year because of COVID, and a lot of folks are, hesitant to see family because of COVID, and people have, personal decisions to make about that right now. And some folks are choosing not to see their families this year because of COVID, and other folks are deciding to, go ahead and take the risk. Whatever you decide to do, I hope that, you do stay safe and healthy, and that you do try to have as an enjoyable Thanksgiving as possible. I find, not to get preachy with you guys and too mushy, but I do find it personally very helpful for me to keep a gratitude list. Camera's not going to work. To keep a gratitude list. And, Thanksgiving is, of course, the prototypical time to start doing that, right? And keeping a gratitude list is one way also that I also combat my own struggles with depression. So it's one of many tools in my toolkit that I use. So I hope that you can find things to be grateful for this week, not just this week, but throughout this holiday season. And when we come back on Monday, we'll be, on the home stretch here. And I hope that you've had an enjoyable experience in this course. I think the course evaluations are open now. So I encourage you guys to get those filled out. And I'm always open to the feedback that I receive from students. I know it's been kind of a crazy semester, and there have been a couple of points where I've gotten behind on grading things at various points. So I accept that criticism, and I'm working to improve on that. But in any case, I am providing 5 points of extra credit for those who do choose to complete the course evaluation. I can see whether you've done it or not. However, I can't see what you put on the survey, so I can only see whether you've done it. So if you go ahead and get that done, I'll be creating an extra credit opportunity for those of you who complete that. And those surveys don't get opened up to me actually until the holiday break. I won't see them probably till a few days before Christmas. But I always look forward to reading that feedback. Even when there's negative feedback in there, it's still useful. So, all right, guys, I've kept you guys 2 minutes over. So everybody have an enjoyable week and a nice Thanksgiving. Stay safe and healthy, and live long and prosper. I'll see you guys. I'll see you guys next. And I kept saying Monday. I'll see you guys Tuesday. I just realized that I've been saying Monday this whole time. Tuesday. I'll see you guys on Tuesday.
Have a good one.
You too.
Happy Thanksgiving.
Have a good Thanksgiving.